Having completed the examination of the head, we're now going to go on to the examination of the neck, and particularly the soft tissues of the neck. I'll point out the major prominences and landmarks of the neck. So, first of all, starting from the bottom, of course, there are the clavicles on either side and the suprasternal notch. Within the suprasternal notch is the trachea. You follow the trachea up, you come to the cricoid cartilage, and above the cricoid cartilage is the thyroid cartilage. Just above the thyroid cartilage is the hyoid bone, felt here between my thumb and forefinger. And just below the angle of the jaw, with deep palpation, we can palpate the bony prominence of the lateral process of the second cervical vertebrae. Patients will sometimes feel that themselves and feel that it's a mass. It's oftentimes quite tender when you palpate that. Other major prominences, if you turn your head to the side, sternocleidomastoid. Remember, the ipsilateral sternocleidomastoid turns the chin away. Sternocleidomastoid on the other side represents one of the major landmarks, and it inserts right here on the proximal clavicles and on the mastoid behind the ear. The last major landmark, of course, is the trapezius muscle, which gives the neck its smooth bowed contour. The trapezius inserts up along the cervical spine and the base of the skull and down all the way onto the clavicle, as well as onto the scapular spine. To palpate these structures, we palpate both from the front and from the back. For the posterior neck, again, I palpate from the front because the hands are very comfortable in this position, and you're just rolling the soft tissues between your fingers. Particular attention to the suboccipital area for any lymph nodes in that area. Palpate also from the front, which I find is much more comfortable and much easier to delineate structures in the anterior neck, particularly the thyroid gland, which sits just below the cricoid here and is easier to feel from the back. So we'll start in the submental area. Just relax your chin down a little bit. Feeling for any lymph nodes, again feeling the submandibular gland in this position. And then continuing to palpate down the anterior border of the sternocleidomastoid, retracting the muscle a little bit so you can get under the muscle belly, and continuing right down to its insertion on the clavicle. Remember to palpate also the lateral posterior border of the sternocleidomastoid for nodes, masses, or any other abnormalities. Pay particular attention here to the left side, right where the posterior to the insertion of the sternocleidomastoid. There's a famous node called Virchow's node that may signal the presence of intra-abdominal cancers that metastasize up the lymphatics. Also palpate the supraclavicular fossa. And you can palpate the infraclavicular fossa at this time as well. This is also a good time to check range of motion of the neck. You have the patient bend the chin all the way down to the chest and then all the way back. It's excellent range of motion. Turn to the right side and the left side. And then lateral bending, the ear towards the shoulder, the ear towards the shoulder. Excellent. Next, we want to try to palpate the thyroid gland. Thyroid can occasionally be actually seen in the anterior portion of the neck, right in this area. Certainly, if the thyroid is enlarged, you may be able to see it. Tangential lighting can sometimes help you identify it, but that's not a routine observation. To palpate the thyroid, you first start by identifying the thyroid cartilage and then moving down to the cricoid cartilage in this position. Position your index fingers just below the thyroid cartilage, and then bring your fingertips together in the midline in that position. gentle pressure on the soft tissues of the trachea and ask the patient to swallow. Okay. When he does that, the muscles of deglutition or swallowing up here in the pharynx are attached at the base of the skull and pulls the soft tissues upwards, including the thyroid, which is attached to the anterior aspect of the trachea, and the thyroid will roll underneath your fingers. It's quite easy to palpate. Occasionally, the thyroid gland will extend under the sternocleidomastoid, so you may need to retract the sternocleidomastoid to feel the lateral borders of the thyroid. You should always practice feeling normal thyroid glands. They're fairly easy to feel in people with thin necks. Obviously, with very large necks or obese necks, that can be quite difficult. Another way to examine, the lateral aspect of the thyroid, lateral aspect of the thyroid is to displace the thyroid cartilage right here a little bit laterally, and then you're able to palpate the thyroid posterior to the sternocleidomastoid with the fingers here and the lateral aspect of it with the thumb. And that's useful if the thyroid is enlarged and extending behind the sternocleidomastoid. Occasionally the thyroid will actually descend into the anterior neck and you may not be able to feel the lower border. It takes a lot of practice to feel the thyroid comfortably, but it's well worth spending some time on that. So that's the palpation of the soft tissues of the neck. Next thing we want to do is examine the vascular structures of the neck. So the carotid artery can be easily palpated here at the level of the thyroid cartilage where the carotid bifurcation is. Remember to palpate one at a time, not both at the same time, with very gentle pressure. And be sure to auscultate the carotids as well for bruise. Ask the patient to hold his breath. Go ahead and breathe normally. And hold your breath again. Good. The venous structures of the neck are visible occasionally in the normal state. The external jugular vein can occasionally be identified in the sitting position. The internal jugular vein cannot be seen, though the pulsations can be seen. We'll lie the patient down and take a look at those pulsations a little bit more closely. Let's have you lie on your back. I'm going to raise the head of the bed just a little bit. Okay. So we have palpated the carotid arteries on either side. Now we're going to try to see the major veins in the neck, the external jugular. The internal jugular really can't be seen directly, but oftentimes the major pulsation we see in the base of the neck is actually due to blood distending the internal jugulars, not, as many people believe, to the pulsations of the carotid artery. To demonstrate that for yourself, when you see prominent pulsations, just gentle pressure on the base of the neck just above the clavicle in this area. Obviously not hard enough that you would occlude arterial circulation, but enough to occlude the venous circulation will eliminate that pulsation, and what you will see is just the continued pulsation of the carotids up in this area, but not the expansion of the whole base of the neck that you sometimes see. The external jugular can usually be identified by pressure over the lateral neck. A good way to find the correct spot is to have the patient do a Valsalva. So I'm going to ask him to take a big deep breath, hold it in, and then bear down hard. This inhibits venous return, and now we can see the external jugular vein here prominently in the neck. Go ahead and relax. So we'll identify the external jugular by having him take a deep breath and hold it. and bear down. The Valsalva maneuver inhibits venous return, and now we can see the external jugular vein here distended on the lateral side of the neck. When he releases that, this vein collapses completely down to at least this area. We know that the right atrium is in the middle of the chest, so his central venous pressure really is not more than 3 or 4 centimeters, or quite normal. So that's one way of evaluating the central venous pressure, by examining the neck veins. So that completes the examination of the venous structures. Lastly, I think it's very important to examine the suprasternal notch. This is oftentimes neglected. What one does is put index finger right in the suprasternal notch, and the trachea should lie square in the middle of that, and you can palpate the tracheal rings as it comes down, and they should be right in the midline. It can be a little uncomfortable for the patient, so don't push too hard. But if the tracheal rings are not centered, then that means there's some deviation of the trachea inside of the chest. Lastly, rarely, but it has been described, you can feel pulsation in that area of a large aortic aneurysm that involves the arch of the aorta. So with examination of the neck veins, we've completed the examination of the soft tissues of the neck, and we'll move on to the next exam in our series.